Satish Kusuri, Professor of Civil Engineering. Thank you, Satish, for joining us today. My name is Tommy Soares. I'm the Assistant Director of the Purdue Institute of Inflammation, Immunology, and Infectious Disease. And we've been doing this research spotlight series for this past year on a virtual mode to highlight the work that people have been doing. We started very much focused on COVID-19, and we have a pleasure today of hearing from Dr. Ukasuri, who's using human mobility data for data-driven multiplex network modeling in pandemics and his insights from COVID-19. So without further ado, Satish, take it away. You have the microphone.
Yeah. Thank you, Tommy. Yeah, it's a pleasure to be here. Um, so usually, I'm at conferences speaking to my colleagues in the transportation civil engineering space. So this is a unusual audience for me. But the purpose really for me here today is one to share our work on using these type of big data sources and network models from COVID-19. But the second purpose is also to kind of look for potential collaborative opportunities in the health sciences space to see how we could make these models more useful and how we can translate them for informing policy making in the health sciences and public health space, right? So today, my background is in urban science, and I'm primarily applications in smart cities transportation space, and the methods I particularly use are in networks, machine learning, AI, data science, and I teach classes in those on those topics, right? So what I really want to share with you today is related to the role of urbanization on infectious diseases, right? So this is something I want to kind of briefly talk about, then jump quickly into the opportunity that we actually see in the use of big data for monitoring, understanding response issues and recovery issues in pandemics, then really talk about this idea of scale and how scale comes into play, both spatial as well as the temporal scales come into play when we want to understand these type of couple systems where you have systems between urban systems, health networks, and social networks. Then I would like to share some work related to real-time monitoring of data during COVID-19. Then look at the scaling laws that are there in the context of urban disease networks. And finally, kind of touch upon multiplicity and the feedbacks that are there in these networks, right? So there's kind of a hierarchy in these topics, right? So first, this is mainly about the data analytics part, not really understanding the underlying process itself, but then how can we use this data that we actually have to understand some of these underlying processes, and are the universal laws that we actually can understand in these couple networks? And then finally, how do we really model these things so that we actually can do predictions based upon this, right? So my talk will primarily focus on this part here today, but I'll also touch upon some ideas related to these two based on some of our recent work. So if you see, the division between urban spaces and wildlife and all of this is reducing. So cities are growing. There's a big movement in terms of people from rural areas to cities. Cities are becoming zoonotic hotspots, right? And urbanization is increasing all over the world. And because of this, there are boundaries between urban, rural, and then the wildlife boundaries are actually decreasing. So this is something, this picture here captures some of these interactions that we actually see. This is from a recent paper in this Ecology and Evolution journal, not our work, some of the first people's work here. So this kind of shows the interaction between urban landscapes and local systems, and the kind of movements that are there, the human movements the domestic animal movements, wildlife movements, environmental flows, and so on, and the different types of scales which are there in terms of these movements and how that actually interacts with uh, the probability of infection, prevalence, and so on at the local level, right? So this is happening more at the regional level and global level. And then the kind of interactions that are there between the human movements with the changes that are actually happening at the local system and its influence on the ecological landscape and its impact on the disease propagation, right? So these type of system diagrams which help us to capture these dependencies that are there between various kinds of urban ecological and the infectious disease spread is something which we are seeing more and more due to rapid urbanization. And this is also borne out by the data. So, right? So if you see this chart here, we can see a greater mobility across the world, right? If you look at the amount of international travel that's been happening, you can see the rapid increase from 1950 till today, right? So from about less than 100 million to more than 1.5 billion trips that are actually happening in terms of tourism, right? So there's a greater movement of people across the world. And these movements increase the interactions and the contacts of people to people, but also people to with all the other wildlife, increasing the opportunities for spread of infectious disease. So the work that we actually have been doing over the last 10 years is to use high resolution data and data from mobile phones. Mobile phones are used by almost 6 to 7 billion people in the world for various kinds of purposes. Most of these mobile phones have geolocation information, and there are data vendors who actually save these location information, and we work with these various mobile phone vendors to get that mobile phone location information to understand mobility patterns, right? So these are high resolution, large scale mobility patterns. So for example, in the US, about almost 280 to 300 million users are there in these data sets, right? So some work which we're doing in Africa, the representativeness is much less. It's about 5 to maybe 10% of the people across many years, right? So you have this kind of geolocation information, and we have been working with various data vendors, and these data vendors store the information, and there are a lot of issues related to privacy and how you actually store this information and so on. And there are methodologies to address each of these things. So we can get into some of those details if there's interest. So these are some of the vendors that we actually have worked with, and these vendors have geolocation information. So Google, for example, is in this space, which has provided mobility trends during COVID. This is a map from Facebook, movement maps, and they use the tile level information of these movement maps, right, which shows the decrease in mobility during COVID, right? SafeGraph, Unicast, Quebec, and so on. So these are all mobile phone data vendors. And we work with this to really understand the urban dynamics, to see how people's travel patterns and mobility patterns are changing with time, right? But also as a function of the shocks, both major shocks as well as minor shocks that are there in cities, how are people changing their travel patterns, and where are people actually traveling to, which people are reducing their mobility, how far do they travel, what type of points of interest do they access, what is the impact on business locations, and so on, right? So this data helps us to really stitch together the urban dynamics that is kind of unfolding in cities. So we have been using this primarily in the context of disasters over the last 10 years. In the last 5 years, we have been working in the context of using this urban networks, plus given the interaction of urban networks with disease spread, we have been trying to bring together this urban movements with understanding disease spread, right? So kind of looking at the couplings between urban networks and epidemic networks. So this work we started almost 5 years back, and with the pandemic, I mean, it has kind of gone, it has become very big and a lot of interest and a lot of new data sets that have become available from these data vendors. And we have been very, very busy over the last year trying to kind of address some of these important questions. So here are some of the features of this kind of mobility data. So this is GPS data from mobile phones. The sample is about 1 to 5% of the population, depending upon the city, depending upon the country. This is from, especially from Yahoo Japan data in Tokyo, about 50 to 100 points, data points per user per day. And using this, we can estimate their stay locations, including their home location approximately. It does not contain any demographic information, right? But we can look at the representativeness at some spatial resolution, either at administrative boundaries like census tracts, zip codes, and so on. People have talked about this issue, which is that there could be bias in terms of this mobile phone location data in terms of some socioeconomic population growths. This is an issue which we kind of really look at very carefully when we get into the analysis to see how representative the data is. There is some discrepancy when you look at this in the context of maybe wealth and gender. But overall, when you look at representativeness at the spatial scales, we see that in most of the urban areas, it is pretty representative. So now let's get into some of the important questions related to understanding how mobility restrictions were impacted during COVID using this mobile phone data. And this is work is mainly from 2020, some recent work from 2021. So almost a year back when we started this work on COVID, right? So all the countries were imposing strict lockdowns to stop the spread of COVID-19. And you can see that various countries, the economy has taken an immediate hit. And then the countries have kind of increasing number of cases. These look minuscule by the standards that we actually have today, right? Very few cases. But if you see the numbers today, they're much, much higher. So the question is, one, we want to really understand using this mobility data, what type of people, where did people travel, right? How much of restrictions did people actually have on their mobility as a function of these lockdowns that have been imposed in cities? Which people were able to reduce this type of mobility patterns? Who could not? Are there any inequalities in terms of these type of restrictions? What is the relationship between mobility, right, in terms of people coming in contact with each other, thereby developing these contact networks, and then the underlying infection rates measured in terms of the RT values that are there for the cities, right? So is there any kind of a relationship between the mobility patterns and the RT values that we actually see in cities? And then can we take a deeper dive into some of this analysis by looking at different types of points of interest, let's say for schools or other critical services like hospitals. And if you look at like, for example, malls and businesses, what's the impact on each of these different types of facilities in terms of the visits and the potential economic consequences that are there due to the drop in terms of this foot traffic, right? So we can also kind of look into those kind of issues. So I will kind of show some of these things using Tokyo as an example, right? But similar type of analysis we have done with some other cities in the US. And if there's time, we actually can talk about that. So Tokyo is a very unique case because people have started restricting their mobility even before the state of emergency, which was issued in the second week of April last year. And you can see that the timeline for the number of cases that are there in Tokyo over time. And even before the state of emergency, you can see that mobility was actually kind of dropping at various locations. And there were no strict lockdowns in Tokyo. There was only non-compulsory, non-pharmaceutical interventions that were actually kind of recommended. Here is using the mobile phone data with our collaborators in Yahoo Japan. Here are some 3 snapshots of these data points, right? So these are some of the major transit stations in Tokyo. And this is a snapshot on January 20th, on March 30th, and then April 14th. And you can see the kind of reduction in terms of the number of riders that are going to these transit stops, decrease of about 45 to 50% in many of these stations, and decrease of about 70 to 80% by April, right, in terms of the total number of visits. So you can see using this data, which stations and which facilities people are reducing their travel, from which locations are people actually able to reduce their travel. And how did these people's contact patterns change? And if so, how does this relate to the transmissibility of the COVID-19 in Tokyo? So that's our next question. And here is some more analysis in terms of the mobility patterns, right? You can see that the travel distance over this 4-month time period that we have analyzed, right? So this is about a couple of million users. We have this data every few minutes, right, for about 4 months. And you can see that the travel distance in this 4 month as compared to sometime in early January, you can see it's reduced by about 40%. Okay. And the stay at home rates, okay, have increased by about 50%. Okay. The number of people who are staying at home has increased by about 50% from early January. So people staying within 3-kilometer radius from their home location increased by about 50%. So using this data, the other thing which we would like to kind of do is we would like to kind of build the social contact network. So what's the social contact network? We want to see which people are coming in close contact with the other people within the network. And we also want to look at the exposure. We want to look at how long do they actually come in contact with each other, right? So in this study, we haven't really considered the duration, the exposure time. In one of our current papers, which is in review, we actually have also come up with a metric for considering this exposure time. So the social contact index is the relative amount of spatial co-locations between mobile phone users compared to the pre-COVID weekdays. So we have normalized this to kind of look at how many contacts have increased or decreased with respect to the pre-COVID. And these contacts are less than 100 meters and greater than 30 minutes. So what we can see here is that the contact index, right, defined here, reduces by about 60% before the state of emergency. Even before the state of emergency was issued, you can see that there's a reduction of about 60%, right? So this is across the city. This is not for any specific activity. It's not for schools or malls, but it is across all of these different activities. And after the state of emergency was issued, these contacts reduced by almost 80%. Now let's look at the disparities in terms of the income, right? So this is something which is very important from a policy point of view to see if there are any inequalities that exist in terms of who could reduce this mobility and who are able to reduce these social contacts. And if you see this graph clearly shows, right, when you look at the income is measured by looking at each of these administrative boundaries and looking at the census data and looking at the average incomes that are there in that and correlating it with the contact index, the average contact index for this same location. And we can also account for the deviation, right, in terms of this contact index. And if you see this, what we clearly see is that the higher income locations and the higher income households thereby, whereby if we're able to reduce more contacts or could restrict their mobility more as compared to people in the lower income ranges, right? So this is something, by the way, we see the same thing in New York, in Chicago, we have done this similar analysis. In Indianapolis, so we have done this similar analysis. So this insight translates into various cities, both I think across the world. The other important insight from this study was to look at, well, our cities may be doing too much. So if you recall, almost a year back, one issue was maybe it's strict lockdowns are not necessary. Maybe we don't need to close down all businesses. Maybe some businesses can be kept open and still contain the disease and so on, right? So the cities were getting very anxious about the economic toll that these mobility restrictions are going to actually have. So the question which we kind of looked at was, well, is there something called a strict, very strict, too much we are doing in terms of these lockdowns? Is there an optimal amount of lockdown that is sufficient for us to be able to still keep the economy functioning, right? And this is one thing which we have presented to people in Tokyo. And what we see here is that, yeah, yes, indeed, there is a diminishing marginal returns that you actually get in terms of reduction of these infections beyond a certain amount of lockdown, right? So beyond 0.34, the amount of gain that you actually get here in terms of reductions of RT are not really significant. So you don't need to have, but in Tokyo, actually, it goes beyond that. So you don't need to have those kind of strict lockdowns. So the related insight is then which businesses should be kept open and which facilities can be kept open, right? And so on, right? And we have a nice policy brief which we did for the Asian Development Bank, discussing some of those nuances of relationship between these type of lockdowns and the economic impacts. A quick note, we don't really consider some of these other things people might be doing to reduce the infections. We are just looking at the correlations between mobility and the RT values. So people could be, some locations, people could be taking other types of protective actions, such as wearing masks and washing hands more frequently and things like that, right? So if we can complement this data with some amount of survey data, that would actually help us to make more stronger and better inferences about the policies. Um, so yeah, this is the social contact reduction. So we don't need to really reduce the social contacts by more than less or less than 0.34. And this varies for different kinds of businesses, right? So for some of these businesses, you see that like transit stations, there's been a significant drop. Some of the parks, there's been a significant drop and so on. So in Tokyo, actually, you can see that there is an excessive social contact reduction by about zero point 0.2, and we see that 0.34 is just enough for us to be able to get the maximum RT reductions in this city. Okay, so I will stop the discussion. So anyone interested in this particular study, you can read the full paper published in Scientific Reports last year. So this is the citation, this is the excerpt from the paper. Um, After this, I mean, there is a lot of things you could do with this data, right? So there's a lot of work which we are currently doing with this data. So this is data from SafeGraph, which is one of the mobile phone data vendors I showed before. And we are also interested in looking at the social distance, right? Which locations people are practicing social distance, and how is the social distance metric changing across time, changing as a function of the lockdowns and the type of organizational policies that are in place, and how is this changing across maybe within the same state across different counties and so on and so on, right? So we have come up with a metric which considers social distance, which is the distance between visitors at different points of interest, assuming that they're making some assumptions in terms of how they're actually located, but also considering their exposure, considering the duration of time that they actually stay within that particular location. And if you look at some of this data, I'll just show some quick graphs in terms of the reductions, right? So this is from February all the way until early July time period. And these are the different kinds of businesses, right? Daycare centers, fitness centers, gas stations, malls, restaurants, schools, and so on. And you can see that there's been a drop of almost 70 to 80% depending upon this, right? So the pink one here, supermarkets, not so much, a reduction of about 40 to 50%, whereas schools, you can see a drop of almost 80 to 90%, right? So schools and hotels saw the sharpest decrease. And you can see there's a small uptick that you actually see after June time period, right? So whereas hospitals and coffee shops, not so much decrease. And you can do this. This is in New York City, and we did this the contact distance, where the people are how the social distancing is actually changing over time. um, and you can see that the yellow line here represents the contact distance, right? So that's actually decreasing, but after a certain amount of time it's actually a little bit increasing, right? So at daycare centers, and the population here is about 3.3 million users who are visiting these daycare centers. So n represents the number of users that are there underlying this data set. So you can see how the distance is changing, right? And you can see the number of visits. These are the number of visits which are decreasing, and then the contact index, which is actually increasing in feet. So you can see how that is changing for all of these different types of facilities, right? So the contact distance, for example, a fitness center increased, but then slowly started dropping after a certain amount of time. Schools, it remained pretty much the same. Malls, it started dropping and so on. So you can kind of look at how the social distancing metric is changing by business type, by time of the week, by location, so on and so on, right? You can also correlate the mobility with the RT values, as we have done before. So this is for New York City again, and this is from January till late June, early August time period. This red curve here represents the RT values, how the RT is changing. First case on early March, lockdowns, right? Two lockdowns, one in March and one in May. And you can see that a drop in terms of the number of visits, right? So you can see that almost 90% drop, slowly coming back up again. There's a many of them are bike trips and so on. But you can see a clear correlation between the RT values and then the drop in terms of these mobility patterns that you actually see. And then you can look at contact time, social distancing metrics, some of the things that we actually discussed before. So same thing we actually have done for Chicago here. Slowly picking up again, as you can see here, right? This is last year, and same for Seattle. And this is based upon income groups, right? So you can see that the income groups, how the number of visits by income groups is changing in New York City, Chicago, and so on, right? So faster recovery in terms of so greater decrease first in the higher income group people, and also a sharper slope in terms of the recovery, not so much in terms of the lower income groups. Okay. All right. So that's the first part of my presentation. Uh, I'll keep this second part quite brief, which goes into now. So the previous analysis was primarily using this high resolution data, right? And then doing the data analytics using ML tools and so on, and then making predictions. You can also make predictions based upon that. But one of our other important research goals is to really model the underlying process so that we actually can connect the underlying behavioral process of people's movements with the underlying the disease dynamics so that we actually can bring them together, right? So this modeling of this interplay of this human mobility networks with the infectious disease networks is something which we are interested in. And so the SCIR is the classic model from in the epidemiological literature to kind of look at the spread of the disease. So our goal is to kind of integrate this with the mobility layer, right? So where we have movements of people from home to work, and they use a transportation system where there are a lot of contacts that they come in, and then they actually do other activities once they reach their next location. And so we look at the travel contagion, we look at the activity contagion, and to integrate this in terms of creating what we call a transportation SCIR model, like a SCIR model. So without really going into the details of the model, right, and the underlying, so we do a lot of mathematical modeling of this infectious disease with the urban networks. and we can capture the underlying generative mechanisms so that we are able to build a bottoms up model, which will help us to kind of inform various kinds of decisions. And two, we can do predictions based using this kind of a model. So we have applied this model, right? So this trans SCIR model in New York, and we have aggregated the zones in New York based upon some of the administrative boundaries that are there, right? So for example, all of Staten Island is captured by one single node, Manhattan by multiple nodes, right? 3 nodes here, Queens by 4 nodes, Brooklyn by 5 nodes, and so on, right? And Bronx by a couple of nodes. So we have aggregated this, and what we have done is we have integrated both the mobility patterns, the mobility data that we actually have from the transit movements of people, from the mobile phone data movements, and then looking at the estimated RT, the infection rates that are there in each of these different locations from the NYC COVID data. And then what we see is 28% of these total cases during early outbreak, but varies significantly. There's a lot of heterogeneity in terms of these different types of locations. So I think the key thing is once we use this model, you can kind of make predictions for future time intervals. And this dotted line is the reported data from the city, right? So this dotted line represents the reported data from early March to early April, whereas this thick line here is the predictions based upon the SCIR model. And you can see that there's a pretty good agreement in these type of in these days that are there. There's some difference in some of these days. So, but we can also make these predictions at a more disaggregate level for each of these different zones that are there in this particular city, right? So that's what's shown here in terms of the predictions due to travel contagion as well as the activity contagion, which is actually there, right? So you can kind of see what's the share of these type of infected population in each of these different locations. You can also do various what ifs, various types of counterfactuals with this kind of a model, right? So what we have done, we have created some counterfactuals, right? So I would take these insights and then the assumptions with a grain of salt, right? Certainly we could use a public health expert to strengthen some of the underlying assumptions in this modeling framework. Um, so here, essentially what we have done here is, so we have put various kinds of controls in the sense of like entrance controls by restricting the mobility of people, right? Putting capacity in terms of how many people can use transit. So if you reduce the frequency of transit, not a lot of people can actually use transit. So by putting certain types of controls in terms of the frequency of transit, limiting the capacity at transit stations, if you were to do some kind of a control, you can actually reduce the number of contacts that are there. And the earlier you actually can do this, the more effect it actually has into the future, right? So this graph here shows what happens if we were to put these type of controls in terms of the suscepted population, in terms of the exposed population, in terms of the overall infections. These were the original number of infections that are there. And these are the ones when you put this control. So you can see that the peak is actually pushed from early May to early June. And then the peak is also much more flatter, right, by putting this type of a control. So you actually can see the effect of various types of controls that you put, how that feeds back into the infected population, into the recovered population. The recovered population is showed here. The recovery is also faster. And you can see the effect of these different types of controls on the infected, recovered, exposed, and susceptible populations. And then you can kind of look at various kinds of effects of various kinds of interventions. So this one on the right here shows if you were to allocate your budget differently in different locations. So these are the locations, right? And if you were to allocate your budget, either in terms of manpower budget or in terms of your dollar budget, right? In these different locations, how much of benefit do you get in terms of reductions of these infections? So you can also do this type of various resource allocation type of scenarios and see which one is more useful, how much should you invest in terms of these interventions in these different locations. So this study is published in this journal here in Transportation Research Part B recently, and so you actually can look at this. So it's a mathematical model which looks at a very nice the state of the art epidemiological model with a very nice mobility model, and creates this kind of a data driven network based multiplex model which can help us to look for various kinds of test various types of counterfactuals. Tommy, how much time do I have?
I believe you have all the way until, well, we really had half an hour. We typically do, but if you want to continue going, I mean, it's super interesting, and I think people are engaged. You can keep going if you want to until 11.
So
How about that?
I have a couple of other ideas to share, and then I'll keep it to maybe another 5 to 7 minutes, okay? And then we'll stop there.
Great,
Some questions.
great,
All right.
perfect.
So the other idea which I would like to share from our work is to look at, so we talked about data analytics and data plus models, especially in the context of multiplex models, right? But then the next notion is in terms of how do you scale these models? How do you kind of look for scaling laws that are there in cities? And how can you exploit some of the scaling laws in terms of making better decisions that consider both travel patterns as well as the disease spread in infections, right? So I want to kind of motivate this using data from three megacities. Shanghai Metro card data, about 4 million records, right? So from about 289 stations. Shenzhen Metro, about 2+ million people, and Guangzhou, 1.6. So we have access to all of this data, thereby creating the social contact networks, right, for these various locations, right? So if you were to look at the passenger demand, so this is a quick idea of the peaks that are there, right? So peaks during morning peak and evening peak and off-peak time periods in these three metro cities, and travel time distributions. And it shows that there's an exponential decay in terms of travel times, right? So the idea is to kind of construct these contact networks of these mobility patterns of people traveling in these kind of networks, right? So we have basically people who are traveling with other people. They come in contact with other passengers. And depending upon the likelihood of the contact and depending upon how much time they actually stay there, we actually can come up with the weights related to the social contact network, right? And then what we have is we create this contact network for all of the people as a matrix, okay? And this could change with time, and you could give different weights to different locations depending upon how interesting and important they are for you. So these are the graphs, these are the networks. So you can see that the density of these different movements of people and for all of these three cities, right? So Shenzhen is pretty dense, and you can see there are a lot of interesting things that one could do. You can identify hubs within this network, you can identify criticality within these networks. So a lot of interesting things that one could do once you have this type of complex network representation of these interactions. So what we do is we first look at this, what's called a degree distribution. Degree distribution is the edge connectivity, the number of edges that are going out of a given node. And we want to see how that is actually kind of distributed for all of the nodes that are there, right? So this is the node degree and this is the likelihood. So there are some interesting properties for these type of networks. Depending upon the network structure, you can say whether it's a scale free or it has a power law kind of a distribution. And that has implications in terms of the resilience of these type of contact networks, right? So first one, where you want to kind of maybe prioritize your either information sharing or resource allocation and so on, right? So the key takeaway from this here is all the networks, all these city networks, in this case transit, right, share the same type of degree distribution, different exponents, different parameters within the distribution, but they share the same kind of a degree distribution. And we can use that to create an underlying generative mechanism. So we can create a nice mathematical model to see the likelihood of the passenger I getting infected at a time t, depending upon the state that all of these other people have, depending upon the kind of information they also share, right? The type of intervention that's taking place, the information that is available to them, you can actually make some predictions that the population is going to get infected. So what is the multiplexity of this network? So there's a people network, there's a travel network, there is a infectious disease network with all of these probabilities, and then there's an information network, right? So the kind of combination of these different networks into one single framework is what we mean by multiplex networks in this context. Okay, and then you can write down all the underlying mathematical model very clearly, but really like a bottoms up model, you're creating it from the bottoms up framework so that you can see at the top level how this kind of a network behaves, and then you actually can predict the number of infections that are there. And if you were to rearrange the structure of this network, both the physical network in terms of transit station by the closing certain stations, like what they do in China, right? So when they have an outbreak, they reduce the capacity or close certain stations, and then you can see the effect of what happens in terms of the spread of this kind of a disease. So you can test this to incorporate different kinds of network structures and different kinds of policies from public health, and then see the various kinds of what ifs based upon that. So with that background, so I won't go into the details. If anyone has questions, we can certainly talk about the underlying mathematical models more. Um, so what I really want to kind of share as a summary today, the key takeaway from this is that we see in the last year, the floodgates are open for all of these data vendors, right? So we have NDAs with Facebook, with Google, with various data vendors. So if someone is interested in doing this data analytics work, we actually already have the NDAs in place. So we could kind of request new kinds of data sources for this. So this type of large scale mobility data is really useful for informing public health policies, both in terms of monitoring, especially in countries where they don't have a lot of resources to do on the ground monitoring in terms of sending people and surveys and so on. Like we are doing some work in Africa, this is a very good data source, right? And in the developed world, the scale of this data is very significant. It gives us a lot of important insights into understanding the connections between human mobility and then the disease spread. So it could inform monitoring, response, and recovery related issues. It could help us to understand social contacts, inequalities, and then how different kinds of interventions could impact the recovery of these cities. And then provide comparisons and the relationships between public health metrics like RT with the social contact reduction and the policies that are in place. And our work shows across both in US and Japan that you actually can understand the drop in foot traffic and the existence of inequalities in terms of who could reduce travel, how much they actually reduce travel during COVID. And we then can build the multiplex networks linking urban mobility with disease spread. And we actually can scale these and we can observe the scaling properties that are there within these type of networks. So there's I think, a very significant value and potential for developing these kind of modeling frameworks. I'll stop here. Thank you very much.
Thank you so much, Satish. Very interesting work and really eye opener for the types of data that can be layered to start to understand these transmissions. I see the people in the audience, and I'm reminded that Giovanna Carpi from Biological Sciences. She's going to be our next speaker on the 28th, if I'm not mistaken. If not, Melanie, please correct me if I'm wrong. And Giovanna, please correct me if I'm wrong. And Giovanna has been looking at and chasing different variants. I wonder, Satish, if you've considered adding the movement of the different variants of SARS-CoV-2 that are circulating in the population with some of this mobility data to see if we're able to make some sense of how things are moving around, and maybe from a more global perspective too. Are you able to get that kind of larger global perspective from this type of data? Or is it mainly focused on urban type of centers where you have partnerships to be able to get that type of data?
Right. So yes, certainly I think we can understand the effects of these new variants on the mobility, but also in terms of the increasing number of infections. So we could put that as a control variable, right? But the key thing we cannot do is we cannot really know from the mobility data who has been infected by what variant. That level of detail is not available for us, right?
Right.
But at the urban scale, at the county scale, state scale, or the national scale, we actually can understand um, the effect of these new variants in terms of one, mobility, but also in terms of the increasing number of infections. So, for example, right now in India, this week we see the huge surge in terms of the number of cases, and partly that's attributed to the new variants that they actually are seeing from Britain, South Africa, and so on, right? So, yeah, those type of things we actually can observe at the population scale.
Awesome. I don't know if anybody else in the on the call here has questions. Please feel free to unmute yourself.
Yeah. Hi, this is Giovanna. Can you hear me? Hi, Satish.
Yes. Hi, Giovanna.
Very, very interesting, fascinating, and helpful talk. Thank you. I was curious about, I have a couple more than one question, but let's start with one. For the second part of your talk about the multiplex networks, and again, when your scale is mostly at the city level, but how do you, what are your assumptions for the disease you're studying? I don't know if your focus is still COVID. I mean, how do you model what are your assumptions about the transmission mode of the infection disease? I mean, we know the SARS-CoV-2, has transmitted by aerosol, but what about, how can you apply this for, can you adjust your model for different infection diseases at different transmission mode? Or longer period of time for transmission. And I'm talking also because we work with vector-borne disease, so there is also that component of other disease as well, but not something that is COVID. How do you model that, or what are your assumptions?
Right. So yeah, I think, that's, so we are basically using all the assumptions that go into the SAEIR model, right? So there are assumptions in terms of the population. At the population level, we need to get characteristics in terms of the infection rates for a given disease. So we have applied this in COVID, but also we have applied this in SARS, right? So for any given disease, if you're given the parameters that dictate the likelihood of the infection rates, susceptibility, exposure, and so on, right? How fast they're going to get infected, and the likelihood that an individual who is susceptible is going to get infected, and so on. So all the parameters that go into the SCIR model are basically essentially what are going into this. On top of this, we also have this informed based upon the social contexts that are happening, right? So the parameters can be tuned based upon the density of these contacts that are actually happening, and then the duration of these contacts. And these can be tailored, right? I think based upon the kind of data that is there for the infectious disease, whether it is SARS, whether it is MERS, whether it is Ebola, whether it is COVID, right? So these parameters can be trained based upon that.
Yes. Thank you.
And I'd be happy to kind of talk more about this in detail, right? So I think there's interest. I'm happy to share the papers and also talk in more detail.
Thank you. I have a follow-up. Sorry, can I ask another question if there is no one?
Go for it. Go for
it. I'm very interested because I've been, we're doing genomic epidemiologies of malaria and COVID, and so the human mobility data has been some component, views for this disease by other groups. But your example, has been fantastic, and the application is particularly in urban setting, where you said that you're starting some work in Africa. So, and I'm just interested to hear about the challenge about the different type of data you can get from Africa in terms of mobile phone, the fact that there is, within, especially across between countries. So I know that within a country might be easier, but there is, changes of vendor between different countries, or some, if you could share some of your experience so far about the challenges of getting actually accurate and phone data from African country. Thank you.
Right. Yeah. Thank you for that question. So yeah, I mean, one of the challenges right now during the COVID situation for many of the development agencies is that they can't send the teams on the ground to collect any kind of survey data, right? So it's been challenging to actually collect any ground level data, especially using human resources like surveys and so on, which require people visiting homes and things like that, right? So I think this is a huge opportunity for these kind of data sources, which are high resolution, including mobile phone data, but mobile phone data is just one of them, but also the social media data. We have access to that. Then there is data from Facebook and Google Trends data and so on. So certainly, I mean, the representation, I think the challenge in terms of getting this data, as I've shown, we have agreements with the data vendors. So it's not really, the challenge is not really in terms of getting the data. The challenge is mainly in terms of how good is this data, right? So what is it representative? Is there any kind of a bias? And what we see in some of the cities, I mean, we have looked at Maputo, for example, we have looked at Bamako, we have looked at West African city like Nouakchott, the capital of Mauritania. So we have looked at a few cities, and these are, I mean, to begin with, some of these West African cities are sparsely populated, right?
Yes.
But what we see is when you go to these capital cities, I mean, the representation is not too bad. I mean, it's not as great as some of the results I've shown for New York and Chicago, right? But the representativeness, especially for the capital cities, is pretty decent, that you actually can make some good inferences based upon the models that you actually build. To just give you a number, right? So for example, in Maputo, which is the capital of Mozambique, we were able to get about 60,000 users in the capital area for about a 6-month time duration, right? During COVID, from March of 2020 to about October of 2020. About 60,000. And once you clean the data, it becomes more like 20 to 25,000 of users, which is pretty decent for a city of that size.
Right. Thank you. That's very helpful. Great example. I think, sorry, and I realized I didn't have my video on. I think it might be more challenging if you want to look in. So if you want to include data from more rural, if you don't want to if you don't focus on the city, on the capital, that's, I guess, the challenge. If you the data quality and density for the rural, it will probably more challenging, right? So
if you were to I mean, this data is more in the urban areas.
Yes.
But even in urban areas, it's not equally representative. Right? So, but once you go to the rural areas, I think it becomes much more challenging to make any population level inferences using this kind of data. That's true.
Thank you very much. We appreciate it. We'd love to follow up, and I will contact you independently for some further questions. Thank you.
Satish, I had a question related. I worked with briefly with Zhilang Feng from mathematics. Zhilang was modeling rubella and measles in China and trying to help Chinese government with their vaccination protocol. And one of the things that she explained is that it was important when we're looking at these contact points and contact durations is to be knowledgeable also about the cultural aspects. And I wonder if you can comment a little bit about what does that look like? For example, she indicated that, you know, in China it's very customary for the grandparent to pick up the child from preschool because typically the parents are busy working. So if there is a grandparent, they are the ones that go and pick up the children. And so typically the transmission of infectious diseases would jump from the younger children to the older adults that are picking them up at school. And having knowledge of those cultural practices was an important factor. I wonder how you how you feel about some of those factors in your models.
Yeah, that's very interesting. Yeah, I think that's reflected. I mean, we don't explicitly consider those cultural factors as part of the modeling process, right? But that's reflected in terms of our data itself, right? So, for example, we could see in that context people from home going back during the school closure times to pick up their grandchildren, right? So the activity which I mentioned in my trans SCIR model would kind of capture that. That would be an activity that the grandparents are participating in. So the mobile phone data would give us that information that they're making a visit to that location, right? And then they're coming back. And at the individual level, we don't have the infected data, right? But I mean, there could be correlations at the population level that we might see because they would be, if they're infected, they would be not going to, they would not be making the trip in a future time to that location, right? So we would see decreases in terms of, and then they would also kind of show in terms of the infection rates in the health data, right? So we would be able to capture that not at the disaggregate level, but I would say in terms of this aggregate level, we would be able to capture some of those
At a
because,
higher foot perspective, right? A higher
exactly.
altitude, yeah.
I mean, if one were to believe that mobility or culture is captured by the activities that we perform, right?
Yeah.
Then, I mean, where we visit is a function of what we believe in, and what we believe in is based upon our culture, right? So I think, I mean, that's where the translation is coming in, right? So where I go is really a function of who I am.
That's right. That's right. No, that's great. Well, I want to thank you so much. I want to thank everybody also for sticking around with us and joining us today. Fantastic talk. And Satish, let's connect again so that we can maybe continue talking about where we can plug you in.
Yep. Thank you, everyone. Thanks, Tommy. Yeah. Bye-bye.
Thank you. Take care. Bye-bye.